Hi, good afternoon, everyone. Welcome to our first 2024 Senior Council Division Coffee Hour. And my name is Gilbert Doles, I'm the past president of SCD, and I'm very honored to invite our first presenter today. This is the first presentation to the Senior Council Division.
Yes.
So this is happy to present Dr. Dwight Lin, who is a graduate of Cornell University, 1990 BA in Neurobiology and Behavior, and Hahnemann University School of Medicine, 1995. He completed his residency and specialty training in Harvard Medical School in 1999 and is board certified by the American Board of Physical Medicine and Rehab. Over the past 20 years, Dr. Lin has remained dedicated to providing Hawaii with the most up-to-date and innovative technology to help patients avoid orthopedic and spine surgery. His philosophy is that compassionate evidence-guided care and patient education will keep Hawaii active and healthier. In 2012, Dr. Lin took his clinic in a new direction and became the first physician at Queens Medical Center to utilize PRP, which is platelet-rich plasma and stem cell technology for knee arthritis and meniscus tears. 2024 marks Dr. Lin's 10th consecutive year as a Honolulu Magazine top doctor in the field of PRP for arthritis and sports injuries. In addition to many memberships in the American Academy of PMR, North American Spine Society, American College of Sports Medicine, and American Board of Independent Medical Examiners, he works with a PLCP, a national group of physician life care planners. When he's not in the clinic, Dr. Lin is devoted to his family, and in his spare time, he enjoys teaching his daughters to surf and prefers single fin longboards for surfing. May I introduce Dr. Lin? Thank you very much, Dr. Lin.
Thank you, Mr. Doles. Happy New Year. And thanks so much for having me today. I want to thank the Bar Association for having me here. And we're talking today about a topic that is very near and dear to my heart, which is the topic of orthobiologics. And I realize that's a term that a lot of folks are not really familiar with, but I guarantee that in the next 10 years, you will be hearing this term orthobiologics when you go see your doctor, particularly if you have trouble with knee pain, back pain. And that's something that over 90% of all Americans are going to experience, aches and pains when they go see their doctor. But thank you for that introduction. Let me see if I can get the next slide up here.
Down arrow.
Down arrow.
I think it might be off. There you go.
Okay. So down arrow. Okay, so just some disclosures. I am a physician that works with a group called Regenerative, which is an orthobiologic company based out of Colorado. We have about 70 clinics across the country, and all the physicians are board certified in their specialty, and they practice regenerative medicine. We'll be talking more about that today. I'm also involved with Recelerate, which is a veterinary orthopedic stem cell company. And you might be wondering how human doctor would be involved with the veterinary company. Well, our thesis with the veterinary applications was that back in 2012, before the FDA approves a human off-the-shelf cell product for treatment, they're going to want to see animal studies first and animal products. That was our intent there with Recelerate. But just, those are my disclosures. And I am in private practice here in Honolulu. I've been practicing for 23 years now. So I'm sure that anybody who pays attention to sports or even looks at the news has heard about various folks getting injuries, back pain, knee injuries, knee arthritis. And if you go to your doctor, the most common type of treatment for the past 50 years has simply been cortisone shots, arthroscopic surgery, and then joint replacement. And that's kind of been the standby. And what's interesting is if you see what a lot of elite athletes have been doing, you see pieces of this on the news, you hear about so-and-so, Steph Curry, getting a blood injection, or you'll hear about football, NFL players having class action suits against the NFL because of repeated cortisone shots. And you're wondering, well, where are all these treatments directed? What's the purpose of these treatments, and are they accomplishing what they're supposed to accomplish? Well, today we're going to be talking about knee pain. What is that? And what are these types of treatments that doctors are using now? Platelets, what is PRP, what are stem cells? And then we're also going to talk about FDA regulations and safety. So if you're here, hopefully it's not because you personally have trouble with your knee or back or something like that, but if you've got a healthy interest in medicine, hopefully you take away some value information for someone that you know who has trouble with their joints, or maybe a client, or maybe a colleague that you know from the tennis court or from the golf course. So this slide kind of sums up my feelings about medicine going back about 10 years ago. And the first frame, you have the older doc who's saying, "Good morning, boys," the younger docs, how's the water? And a few frames later, the younger fish say, "What is water?" And the point of bringing that up is medicine is a very conservative field. Doctors are very good at following algorithms and sticking to a path. But I think where we need to go as physicians these days is we need to have a healthy appreciation for the data and the research. We also need to be looking ahead. There's a lot of things that our regulatory system with the FDA puts constraints on us, and that's for our safety, sure. But at the same time, we need to be looking ahead because, and we'll talk about this in some later slides, there are situations in other countries where the technology is moving ahead of the US. And it could be a blessing, it could be a curse, but the FDA regulations are there to help us and protect us. So we are trying to look ahead. So why is this important? Why are orthobiologic treatments like platelets and cellular therapies, why are they important? Well, if we look at the trend in our population, we are shifting towards older patients taking up more of the census. And I'm included, actually, yesterday I turned 56, so I'm definitely in that demographic where in the next 20 years, statistically, I will probably need some type of orthopedic surgery. And if you look at where this is going, projections, we're seeing a much more exponential increase as that population ages. And why is that important? Well, if you look at the cost for aches and pains, our knees and our back injuries, sciatica, we're looking at about 125 million Americans that are generating about $200 billion in costs. So it's a significant cost to our country, especially when you think about just looking at the one surgery that most folks are going to be thinking about at some point is that knee replacement currently costs around $38,000. So as the population demographic is shifting and more of us are going to need it, we need to look at, one, is that a proper use of those resources? And are we getting the outcomes we want? This slide is taking us back about 10 years. I think this came out in 2013. It's an article in the New Yorker. Yeah, we talked about this at the beginning of the presentation. Is typically when it comes to arthritis and aches and pains and sports injuries, for a long time, it's been medications, physical therapy, and then surgery. And those are your choices. And to me, that has been a big problem in medicine. I feel like a lot of doctors are so stuck in that track, focused on treat the pain with medication, treat the pain with surgery. That is why we ended up with the opioid epidemic. And that was driven by pharmaceutical industry, it was driven by a lot of other, monetary incentives, but basically that type of approach, we're looking at knee pain as a diagnosis, is something we need to step away from. And that is where the difference comes in with a field like orthobiologics or regenerative medicine, because we need a paradigm shift. We can't keep looking at pain as, do they need surgery or not? We can't keep looking at pain as a diagnosis. It needs a medication. We need to look at it in terms of what is the pathology, what needs healing. And again, we look at a surgical approach. It's very much, okay, if you've got worn out knee joint, we're going to amputate the distal femur and amputate the proximal tibia of the shin bone and put metal in there. We talk to a pain clinic. The approach is, we have pain, we're going to give you a medication so you don't feel the pain. We're going to do a procedure to burn that nerve so you don't feel pain coming from that part of your body anymore, or do an injection so you don't feel pain anymore. But that really has to change. We need to think about pain not being a diagnosis, and really pain being hey, it's just a symptom. It's your body talking to you, telling you something's wrong. And again, we go back about 15 years ago, looking where we were at the beginning of that opioid crisis, there was a big push to focus on treating pain. And there were a lot of medications that came out during that time period, OxyContin, Percocet, all those things were big revenue generators for the pharmaceutical industry. But there were a lot of us, myself included, who were looking at these types of treatments and standing back saying, this is not how we want to go. We want to focus on mechanism of injury. We want to focus on the healing process. But it's taken a long time for us to get to the point where we can look at those things from a molecular standpoint, from a cellular standpoint, and that's where we are today. Trying to focus and teach patients that pain is not a diagnosis, and really the pain clinic is not necessarily what you want to be. Really what you want to look for is some way to get the healing process going. And when you look at, I'm not going to go through all the points in this slide, but again, we talked about how medicine tends to be very algorithm oriented. A lot of docs are very conservative. That's good. We want safety. We want safety. And so when you look at how things progressed in the early 70s and 80s, lots of cortisone injections, meniscus surgeries became very, very popular during that time. And as time goes on, we looked at Dr. Lanny Johnson, who was an orthopedic surgeon, and he was a pioneer in arthroscopic surgery. And back in 1981, he got blackballed by the orthopedic surgeons in the state of Michigan, saying that arthroscopy was a useless procedure. And we fast forward 30 years later, it's standard practice. Moving forward again, we looked at Celebrex, medications like Celebrex and Vioxx as anti-inflammatories. Again, that's the 90s. We're looking at medications to try and reduce some of the symptoms of knee pain orthopedics. And then moving forward to 2000s, we're starting to see platelets, cellular treatments used by oral surgeons and also veterinary applications. And then finally was in early 2000s, 2006, Dr. Alan Mishra at Stanford published a study looking at tennis elbow, which is a very painful problem, and looked at using PRP to treat that. Small study, but it did show good data. And that's really where we started to see things change. That around the mid-2000s, the medical community started to take a closer look and say, what are we doing here? What can we do differently to get painful problems to heal rather than just hide the problem? Fast forward in 2016, we'll talk more about this. President Obama signed into law the 21st Century Cures Act. So what that meant was we were able to expedite, fast track some of these treatments to get more technology to patients sooner. And then in 2018, FDA released specific guidelines on how platelets and stem cells can be used. All right, so we already talked about this. Arthritis before 2010, a lot of painkillers, anti-inflammatories, Advil, Motrin, acupuncture, glucosamine, physical therapy, massage therapy. That didn't work. You're talking to your surgeon. A lot of these medications, we've been teaching medical students for many years. And in fact, now, if you look at the American College of Rheumatology, the first line of treatment for arthritis is using Tylenol or using Aleve, Motrin, and ibuprofen, anti-inflammatories. But you look at what they're actually doing with those medicines, they're not doing anything to heal the problem. They're just basically masking the problem. Same thing with the cortisone shots. They feel good in the short term. They shut down inflammation, but they're not doing anything to heal the process. We talked about anti-inflammatories and ibuprofen, Advil, Motrin. You get them over the counter at Long's. What are they doing? They're shutting down inflammation. What we know also, though, is they do have negative effects on the cartilage, the cells that actually line the joints. Studies have shown that naproxen, which is commonly prescribed to military personnel, naproxen actually affects a type of collagen that our bodies use to repair. So when you talk to people and say, I've had back pain for years, I just take naproxen before I go golf or surf, and they've been doing this for years and years, that naproxen might feel good for that short term, but it's also affecting the biology of healing. And so again, we're trying to look at now on a molecular level is what is the effect of putting all these medications in the body? What else can we do to nurture the healing process rather than slowing it down? And so if you look at a lot of these medications, ultimately what they're doing is accelerating some of that cartilage breakdown. So what are we doing now? Well, in 2012, a study came out in the Journal of Athletic Training, which looked at inflammation, specifically regards to ice. And I think most people have heard of this expression, RICE, rest, ice, compression, elevation, if you got a sprain or strain. And that's great for the first 24 to 48 hours. But about a show of hands here, who knows what ice does to inflammation? Anybody? When you put ice on something that's swollen, what's it going to do? Reduce inflammation. It's going to cause the blood vessels to constrict. Now, if you want something to heal, what do you need? You need blood flow. Right. So again, we look at these things we've done for years where we've told our athletes, I put ice on it and rest. And then you see a patient who comes in the clinic and says, hey, doc, I said my family doctor, I saw my orthopedic told me to put ice on it whenever it hurts. Well, that action might be healing or hindering some of that healing process. So again, we're trying to rethink how we've been treating things for a long time. And the study in 2012 in the Journal of Athletic Training showed that the ice does not have there's no evidence to support it. Yeah, it feels good in the short term, use it for the first 24 or 48 hours, but there's no scientific basis to keep doing beyond that. Cortisone shots. Anybody here have a cortisone shot in the past 12 months? So, and most people who see their doctor are going to get offered a corticosteroid shot. It goes by the name of Kenalog or methylprednisolone, prednisone. There's different molecular structures in the family, but they're basically reducing swelling. Now, the thing about cortisone is it's been around for 50, 60 years. It's a very effective medication to treat pain in the short term. But what we know is that it will actually be toxic to chondrocytes, those are the cells that line the inside of the knee joint. We know that it can cause damage to tendons and ligaments and cause rupture of those structures. So when I graduated from my training program at Harvard back in '99, I remember thinking, okay, so if we learned about how bad cortisone is for the joints, how come all the pain clinics are injecting so much cortisone all the time? And when I graduated in '99, I think some clinics were doing 5 or even 6 injections of cortisone per year. I think nowadays, even a lot of the pain clinics are kind of, ratcheting back. They don't do as much of that. But the point is, cortisone injections are so deeply ingrained into how most physicians treat pain and swelling that anybody who goes to see their doctor, this is one of the things that you're going to get offered. And again, another study by some of the docs at Stanford looking at what cortisone can do to your body. One of the things that, I don't know if I put the slide in here, which is particularly interesting after COVID, 1 dose of cortisone will suppress your immune system sufficiently where you will not be able to utilize that flu vaccine. So whether you get flu shot or the RSV vaccine, any of the vaccines, cortisone, just 1 dose for a typical knee injection is going to reduce your body's ability to use that vaccination. And that, again, it just goes to remind us that these types of treatments are not just where that needle goes. It's going to have effects in the rest of the body. Something we've looked at in terms of the healing process as well, the numbing medications we use. When you go to the dentist and they numb up your tooth before they clean it or work on it, right? That's xylocaine or lidocaine, which is, I use that in my office. We do injections for folks. But what we've noticed and we've learned is that if you use those types of anesthetics close to stem cells or in the vicinity of some of those cells that are involved with healing, those medications are actually toxic to them. So we need to be very careful if we're going to be doing work with platelets or cells that are involved with the healing process, what types of chemicals we're putting in there. Okay, so we've talked about a lot of the things that are going to slow down our healing process. We've talked about how the standard medical approach is going to slow those things down. Some very common treatments that are used, but we need to focus on the healing process. So people ask me, so Dr. Lin, when you talk about regenerative medicine, are you talking about creating a 25-year-old knee out of a 75-year-old knee? And I got to say, no, we're not talking about that. All we're trying to do is take a look at someone who comes in with knee pain and say, what can we do to preserve that joint? What can we do to nurture the healing process of whatever's causing pain in there? And that's very different, again, from how we look at it from a surgical standpoint, which is, hey, let's assess the patient to determine, do we need to replace this joint? Are they a good candidate for surgery? And those are 2 very different approaches, right? So again, focusing on joint preservation rather than joint replacement is where we want to focus. This slide here is a look at what happens to that healing process. So when you look at the first, I'll draw the analogy of, you think about the last time you got a cut on your hand, okay? The bleeding should stop within 60 seconds. And that's the platelets in your blood that are going to that cut to stop the bleeding. And at that time, the platelets are going to form a scab. And then a week later, the scab falls off and your skin's healed up. And we take that for granted, right? We just assume it's going to happen. But when you look at that from a medical standpoint, from a molecular standpoint, we got to think about what is happening in terms of when the cut first happens, when you get some swelling near the cut and you get some redness by the edges of the cut, and then you get that scar tissue. A week later, it's kind of itchy and pink. And then eventually a week or two later, hopefully that scab, that cut is gone. And that's because at different stages, hours to days to weeks, different cells are moving into the area to turn on that healing process. There's different signaling proteins, cytokines, growth factors that the cells are using to talk. And that's how this healing process happens. So in the field of orthobiologics, all we're trying to do is take those pieces that our body is already using and then putting them where the damage is. But I'm showing you this slide so you can think about when we are speaking of orthobiologics and treating someone, I'll use knee pain as just our model for today. What we are trying to do in terms of improving that pain and range of motion and strength. So platelet-rich plasma is also known as PRP for short. It's been around for 15, 20 years in human medicine now. Studies are very clear. PRP helps for knee arthritis. There's better ways to do it. There's higher concentration, there's lower concentration, but the studies are very clear. If you have knee arthritis and you're talking to an orthopedic surgeon, they should be going over PRP as an option, as a treatment alternative to getting that knee surgery or getting cortisone or physical therapy. I only put a few studies in here, but as of 2016, we've got a slide coming up. There's about 8,400 references to PRP in PubMed. That's at the National Institute of Health. And a few years ago, there were about 200 studies with federal funds looking at how well PRP works. So if you're wondering, does it work? The data is there. We're going to look at some more of those studies in a moment. But again, platelet, PRP, those are taken from a blood sample. So when you go see your doctor, they take just like you're going to get cholesterol checked, they take some blood and then isolate the platelets from there. And I'm not going to bore you with technical slides today. I'm going to try to keep this as light as possible. But basically, again, when you look at your blood, you've got a lot of different cells in there. You've got red cells, you've got white blood cells to fight off infection. You have platelets, which are involved with the healing process. And those platelets contain growth factors and signaling molecules. And that is why those platelets are so important for PRP. We don't want the red blood cells for platelet injections. We just want those growth factors because those signaling proteins are what turn on the healing process. So one of the things that we focus on in a clinic that specializes in regenerative medicine is how do you get the best dose of PRP? When I started doing this 10 years ago, we took 1 or 2 tubes of blood, we spin it in a centrifuge, and we get a little bit of concentrated platelets out of it. And that was good for about 10 years ago, but this is 2023, and research is very clear. As we age, we don't have as many receptors to respond to those signaling molecules in the platelets. So we need a higher concentrate to get a better result. We still see clinics around town who are using a lower concentrate, maybe a 2x or 3x concentrate, which is better than getting a cortisone shot. But our studies at Regenix show that typically for our patients, 50, 60-year-old athletic golfer, if she wants to get some improvement, we're going to need probably something closer to 10 times or 12 times concentrate to get those receptors saturated. And so what we do at Regenix is different because we're using a sterile lab to process and concentrate the platelets at a very high level. And then we always use image guidance to make sure those injections are going to the right place. So just so you have an understanding of what happens when you or a friend or family or a client goes to see someone for regenerative medicine consultation, they should get a solid amount of time with the doctor, a thorough examination to find out what is causing that pain. Is it truly coming from the knee? Is it because they've got a pinched nerve in their back and some of the pain is shooting down the leg and causing knee pain? They should get a thorough exam. It shouldn't be a quick, 5-minute visit with a doctor who comes and looks at the MRI and says, Okay, we'll see in the operating room. It should be a very thorough exam that looks at the nerves, the muscles, and how that joint, how the body is moving. And the procedure itself takes a couple hours. We got to draw some blood, and then we process in the lab, and then we do the injection with image guidance.
At that time, doctor,
Pardon
all
me?
of this is happening in one visit?
So it depends. We do sometimes have patients who will travel from Alaska or Australia or mainland. They'll come here, and because of time constraints, we will get some information via Zoom early, or they'll send their MRI scans in. But typically, we like to make sure we have enough time to assess the patient, explain to them the risks and the benefits and what we're going to do. And then we usually schedule them to come back. One of the things that we always include with that, and I'll talk about this in a moment, is the rehabilitation process afterwards. There's a reason why rehabilitation with the physical therapist is critical, is because we talked about this, the platelets, the growth factors are going to stimulate blood flow. It's going to be a little uncomfortable. As those cells are doing their work, that first week or two is going to be sore, and we don't want patients to lose range of motion. We want them to lose strength during that uncomfortable period. So we do have rehab protocols in place. That's an essential part of this. We'll talk about that in a minute, but the other type of procedures that people always ask about is these stem cell injections. And it's important to understand what are stem cells. So we talk about platelets. Platelets are in the blood. Stem cells are totally different. Stem cells are cells that live in different parts of our bodies, and they have the unique property of being able to differentiate into other types of tissues. Now, the highest concentration of them is going to be in the bone marrow or in the adipose tissue. That is for adult stem cells. We're all adults here, so we don't have any embryonic stem cells. The other type of stem cells is an embryonic stem cell. Now, those are in the developing fetus. And for ethical reasons, we do not use embryonic tissues for treatment in this country. I don't know what else happens around the world, but we don't do that in the US, right? But the thing about the adult stem cells is that they've differentiated, they've developed these cells and reproducing all of our lives to be ready and waiting for us when we need them. And the embryonic stem cells are still new. So what we don't know is, are they going to change and have some type of malignancy or cancer tendency? But those embryonic cells are really unique because they have the ability to truly differentiate to other types of tissue, but we can't use those. Ethical reasons. The adult stem cells, there's a lot of research on. And the two types that we typically see are hematopoietic stem cells. Those are the stem cells in our bodies that specifically regenerate blood cells. We are constantly regenerating our red blood cell supply. And that is one type of stem cell. The other type of stem cell, which is kind of what we're curious about for joints and aches and pains, is the mesenchymal stem cell. So when you hear people talk about stem cells, one of the things you got to ask is, what type of stem cell are you talking about here? The hematopoietic, which is the blood stem cell, or the mesenchymal stem cell? And the fourth item down there, which is a little bit different, they're about the fetal stem cells. Oftentimes when a new mom is going to give birth, and my wife did this, we did this for our girls, is you get a question about a cord bank, where they're going to take some of the cord blood. For that, they are primarily looking at hematopoietic stem cells. In case there's a history of lymphoma, leukemia down the line, you can use those. That's primarily what those are for. But that's not so much for the mesenchymal stem cells. This is a complicated slide from medical school. This is back in the 80s. Dr. Arnold Kaplan at Case Western University was the researcher who coined the term stem cell. And without getting too deep into it, basically, he was pointing out how this mesenchymal stem cell at the top of the tree has the ability to proliferate and differentiate to all these other types of tissues, whether it's bone, cartilage, muscle, ligament. There's different types of cells that initial mesenchymal stem cell can start from. But that was back in the 80s. And what we know now is that stem cell might not really be the right term. Maybe the proper term should be signaling cell, because while those cells can differentiate to other types of cells, what they do very strongly is produce more of those signaling proteins that recruit other cells to get to work, to get the healing process going. This is electron microscopy. It's a picture looking at a capillary. So that's why it's kind of tube shaped. And you can actually see this kind of lacy network. Those are actually what doctors would refer to as stem cells. They're actually properly referred to as pericytes, not PARA, but PERICYTE, because they wrap around the blood vessels. Turns out those cells play a role in regulating our blood pressure. And when you have an injury, when one of these capillaries bursts open because of trauma, these cells are released and they get to work. So I'm showing this image again because as we're going through time, we saw this slide from the 80s, which is what most doctors who went to medical school saw, this old slide. And that was the extent of their understanding about what regenerative medicine was, memorizing this cartoon. But there's a lot more research now showing, hey, we need to look at these cells, what they do, more carefully. So where can we get mesenchymal stem cells? At our clinic, we only get them from you. We don't get them from an anonymous donor. We don't get them from birth tissues. We get them from the bone marrow. FDA says we have to use them the same day. FDA says we cannot treat them with chemicals. We can't grow them. If we do any of that, we've created a drug. And so we follow all those regulations, rules to a T when we do treatments using bone marrow aspirate as a source for cells. One of the slides up here, we're going to look at some clinics, typically in South America, that are advertising stem cell injections. And you might get this from a friend or a colleague the next time you're together somewhere who'll say, hey, I talked to so-and-so, and they're talking about going down to Panama, Tijuana, to get stem cell injections. And it sounds great, but when you look at what they're actually injecting, there's no regulation on that. We don't know who the donor is. We don't know what concentrations. And the main thing I want to point out here is that currently in the United States, there are clinics offering amniotic or umbilical stem cell injections, and the FDA has specifically said that is illegal. Now, we'll talk about FDA regulations in a minute. And again, you're going to talk to people. You're going to go to birthday parties and have dinner with people, and you say, hey, I had an umbilical stem cell injection. But when you look at the data on what those cells are, there's no living tissues in there. And the FDA has been very, very clear about that. The problem is FDA is outgunned right now. They do not have enough manpower to chase all those clinics down. So literally, a lot of these clinics will operate until there's a complication. And then the FDA sends a cease and desist letter. But anyway, so moving along here, talking about how we actually do these injections. Whenever we use a platelet or cellular treatment, we want to use some type of image guidance. Again, this is 2023. Most of us have had an injection at some point where the doctor kind of wipes down with alcohol and sticks the needle in and says, yeah, I can know where the needle's going. That needle is less than 1 millimeter thick. You got a lot of layers of tissue in here. So typically for a shoulder injection, this looks like the doctor's trying to inject here is the bursa. So if you've got someone with rotator cuff or shoulder pain, bursitis, a lot of times doctors will do an injection using ultrasound to very carefully put the medication in that area. You've got the biceps tendon, you have rotator cuff tendons, you may want to avoid injecting. So my point here is that for any of these procedures, this is 2023. If your doctor is going to put a needle in your arm, unless they're giving you a vaccination, they should be using some type of image guidance. And this is actually what it looks like in the ultrasound. This is the humeral head. Here's the rotator cuff. And this is.
Oh, let me see if I can try to move that.
But I'll go back. Yeah. So basically, you can actually see the deltoid. This is bone. Here's the muscle wrapping across, and here's the needle coming in ultrasound. But my point here is just showing you that, the doctors, we have the technology to do this, and this is really the best way to get these procedures done. It's more comfortable, it's safer, it's more effective. So again, image guidance is essential for any of these procedures. And actually, I think it's essential even if you are going to get a cortisone shot, because it's a safer way to do it and use less medication. But studies have shown that 50 to 80% of injections are going to be correctly positioned if you're using, 58% injections, if you're not using ultrasound, are going to be in the wrong spot altogether. But ultrasound guidance has about 95% placement rate. So what are we looking at here for these types of regenerative procedures? One thing to look for, again, you're going to talk to your friends or colleagues or clients. You want to talk to a doctor who does these procedures specifically. You might see advertisements for a plastic surgeon who, by the way, he can inject your knee and your shoulder, and he can do hair implants and, give you a facial too. Well, that's fine. We all shop at Target and Costco sometimes, but sometimes you want to make sure you're going to go to Midas to make sure you're getting your muffler taken care of properly, right? So you want to make sure that the doctor's a specialist. And this means you're going to have someone who's going to take the time to do a thorough evaluation, not a quick 5-minute in and out. And again, the diagnosis is critical. Image guidance. We talked about why the image guidance is so critical. We want to make sure the injections are going to the right place. And this means that we're not doing a general injection. And if the doctor says, I've been doing this for years, I know how to put the needle in, that might be a red flag to say, okay, if this doesn't work, I got to talk to another specialist. And image guidance can be all the difference in the world. If you're putting stem cells into a tear and it's not going the right spot, you're not going to get the results you want. All right. So we talked about our lab, how we use a lab to get a higher concentrate rather than using a generic kit. Most clinics these days are using a generic kit. You get them on the internet for $30. Take a couple tubes of blood, you might get a 2x or 3x concentrate. If you are going to get a procedure done, ask your doctor, how are you going to process this blood? How many tubes are you going to take? If they're only taking a couple tubes a tube, you're probably not getting a high concentrate. If they're taking, not quite as much as donating blood, but significantly more, and they're telling you they're going to process it in the lab, then you're getting a higher concentration. All right. And then finally, our data in our registry. So for every patient that gets treated in a Regenexx clinic, we track that data. And right now we have over 60,000 patients in that pool. One of the reasons why I joined Regenexx is that as a solo practice doc, private practice, I was at Queens for about 10 years. For me to collaborate with my colleagues, there's a lot of privacy issues. And I realized that in Hawaii, when I started doing this, again, I was getting a lot of funny sideways glances. Nobody knew what I was talking about. So by joining this network in 2018, we have over 70 clinics and we have a lot of data we can pull. And that is the best way for us to control what makes the most sense for mild arthritis in the knee, what makes more sense if there's a partial rotator cuff tear. And so we can't do that without the data, but that's what we need to do that. And as an independent private practice doc, that's hard to do, right? And then we talked about dosing, why the dosing needs to be adjusted based on your medical history, your age. Again, the generic kits that most clinics are using, doesn't matter if you're a 17-year-old soccer player, a 37-year-old runner, or 72-year-old golfer. Most clinics are using the same generic kit to draw blood, a couple tubes of blood, but you want to make sure your dosing is adjusted for your medical condition. And that's important. Again, it's 2024. So we should have some higher expectations of that. Okay, so what types of structures do we treat with platelets or cellular treatment? Knee arthritis, rotator cuff injuries. We see a lot of shoulder arthritis. We treat a lot of spine cases, a lot of sciatica. So these are cases where someone may have tried a cortisone shot or two. They tried physical therapy, chiropractor, acupuncture. They saw a spine surgeon and the surgeon's kind of saying, well, it's not really bad enough to replace the disc or do a fusion. And so the patient ends up in a pain clinic taking OxyContin and getting all kinds of ablative procedures. Well, what can we do to try and get some of those structures to heal? And that's where the regenerative component comes in, ideally before surgery, but hopefully as well before they get stuck on opioids or those other types of common treatments. So we talked about the types of treatments and conditions. Let's see here, we talked about a more comprehensive view of these injuries, that pain is not a diagnosis. And this is something that is really important. And I started learning about this when I was at Harvard, which is looking at knee pain, not just where's the pain on a scale of 0 to 10, but what is the joint in terms of how stable it is? Are the ligaments stable? Looking at the quality of the surface inside that knee joint, looking at the nerves and the muscles that control that, how that knee moves, and looking at your patient from a symmetry standpoint, like the body is supposed to be symmetric. And when you take a look at the knee pain from this perspective, looking at these features rather than simply how much does it hurt, where does it hurt, now we can try and treat these in a more holistic way. This is that case I was telling you about from a few, I'm not sure if I was talking to you, Gilbert, or another Sherpa, Greg. This was from back in September, I think it was September. Who knows what happened down there, but there are a lot of clinics operating right now where you don't know what you're going to get. And again, in the US, at least, there are regulations. The FDA has put down very specific guidelines for us to follow, but things still happen. This is back in 2017. The clinic in Florida, there was a clinic doing injections into, I think it was a retinal clinic. And so it is common for eye surgeons to inject medications to treat conditions, but those are eye surgeons. Those are ophthalmologists who've studied for 12 plus years to learn how to do these care procedures. In Florida was a clinic using some, I think they're using, what do they call them? Physician extenders or nurse practitioners or somebody, but they weren't physicians doing these injections here. And they were one of these clinics that was peddling these umbilical or amniotic saline injections. But my point is these things are happening. And so you're going to hear about this, whether it's in your, hopefully not in your legal practice, but on a personal standpoint, you're going to be talking to people and they're going to be asking and talking about these sorts of things. But the FDA is watching, and we responded to this a few years ago. We said, okay, fine. You got all these clinics in the US that are peddling these IV stem cell injections or these amniotic umbilical treatments. Why don't we study it? Why don't we see? So we did. And so some of the doctors at Regenx and some doctors at Cornell and Colorado University looked at taking cells from the bone marrow and then culturing them, growing them to see how many stem cells would come out of it. And they took another product, this Livion product, which is advertised as an amniotic or birth tissue product. And so the purple shows where the stem cells are able to proliferate in the lab. And the white shows how many cells are able to grow out of those umbilical amniotic tissue products. So my point here is we've looked at it. There's lots of advertising going on about umbilical or amniotic tissue products, but our studies show there's no live stem cells in these products. And the purple shows what you get from bone marrow when you grow them out. And the point there is we can look at the data, we can look and see what's going on. This is a slide which is available on the Regenx website. And this is actually from July and looking at the number of randomized controlled studies to look at PRP platelets. And so all the blue circles are randomized controlled studies which show that PRP is helpful. And there's a lot of conditions on here: knee osteoarthritis, hip arthritis, carpal tunnel, lumbar, low back pain. But all the blue circles indicate studies which show positive results. The red is studies that are negative. They didn't show benefit. But you can see there's preponderance here of positive data for PRP. If you look at the website, the Regenx, regenexx.com website, this slide is actually interactive. So when you click on a circle, you can actually see the research study pop up, but it doesn't really work on our presentation today. But this is for PRP here. This is a study looking at bone marrow as a source for stem cells, and similar infographic. The blue indicates positive outcomes. The yellow is not positive, but the point here is there's a lot of data to support these things that we do right now. So when you talk to a surgeon or you talk to pain docs who say that stuff doesn't work, they just don't know the data. And there's a lot of technology available these days. There's a lot of data to support certain types of orthopedic surgeries. There's a lot of data to support certain procedures that pain clinics do to mask pain. I'm not arguing with that. What I'm saying is we have these alternative treatments which are showing good results. So who is this type of treatment for? Platelets, cell treatments. It's for people who want to avoid surgery. And most commonly, we see people who've got knee arthritis. We see people with rotator cuff problems, and we see people with a bad disc in their lower back or sciatica. These are folks who do not want the long downtime or lengthy rehab from surgery. These are folks who don't want the addictive painkillers. We sometimes get patients coming in from pain clinics or surgeries that have already happened. And that's definitely a harder place to start from. Once we start burning away nerves or cutting away things, it's hard to go back. But that's typically who we see is folks who do not want to have to go back into surgery. Do you have a question there?
Real quick. Oh, what about surgery in 2004? And
So it depends on what's happening in there. So for example, if you have someone who had a disc replacement or fusion at L4.
I can tell you a knee,
Okay.
arthroscopic,
Mhm.
meniscus tear.
Yep.
And it's.
Okay. So in the 90s and 2000s, there were a lot of meniscus surgeries getting done and a lot of arthroscopies getting done. And typically, if you want to get a knee replacement, you had to get physical therapy, arthroscopy, and then knee replacement surgery. That was the insurance-based sequence. The data has shown that the typical arthroscopy or meniscus surgery, actually removing some of the meniscus, accelerates the arthritis. So surgeons don't do that anymore. Most surgeons don't bother with the arthroscopy before going to knee replacement. So I think, again, we're looking at, this is 20 years now, or 30 years, looking backwards. People come in, they had a partial meniscus tear, they've had surgeries before. The prognosis is better if they've not had anything cut out or removed, but there's still room for improvement. Certainly there's room for improvement. Yeah, and especially if you had injections with cortisone or gel injection and you've gotten partial improvement, that's definitely something to talk to your doctor about. This has become more of a referral population I've noticed is folks coming in their 30s and 40s who have really badly injured knees. And I think it has to do with a lot of athletes doing much more aggressive things. And they get really bad tears in their meniscus, ACL, and you see these, endurance athletes, these ultra marathoners, and some of them come in, they got really bad damage to their joints and their discs and ligaments. And so when they go see their surgeon, the surgeon says, well, if you're 65, we do surgery for this, but you're 40 or 50, you're too young for this knee replacement, this joint replacement. And that also is a situation we end up trying to work with patients. And the reason why people might say you're too young for a knee replacement or too young for spine surgery is that the typical knee replacement is going to last for about 15 to 20 years. And then they got to remove all that hardware and put it in again. So when someone comes in their 40s and is asking for a knee replacement, they might need that 2 more times in their life. So again, our goal here is to preserve the joint. If you have a client or a patient, someone you like, you love, and they're thinking about that surgery, if they can defer it 5 years, the technology is going to get better for that knee surgery, the material science, the surgical techniques. So we really urge people to talk to your surgeon, find out what the options are. Like, is this, if it's cancer, you got to do something about it, right? You got to get surgery. You got a fracture, you got to do something about it. But for a lot of folks, it's bad wear and tear arthritis. There's some structure problems that don't necessarily mandate surgery right away. So 5 questions to ask before anybody gets PRP or stem cell procedures. Is a doctor a specialist in the field of regenerative medicine? Are they involved with the research database? Is their evaluation going to start with a careful consultation, a thorough physical exam, a personal review of looking at all those imaging studies? And you also want to ask, are the cells coming from my own body? Again, we look at the data and studies show that the umbilical, the amniotic procedures don't have any living cells in them. And we can talk about that. I mean, there might be growth factors in some of those things, but ultimately you're better off with your own cells. Does the clinic count the cells, customize the dose based on your medical history and your situation? And does the doctor use live image guidance? Those are the things you want to ask if you or someone you care about is getting one of these things done. So we have about 70 clinics right now for our Regenix network. And we actually have some in Australia and Asia as well, and UK now. And that's about the major topics I want to get to today. If you have questions about these procedures, the Regenix website has a live database with outcomes on how the knee cases, the spine cases, the shoulder cases go. And that's live data that's updated. And so the other thing that you can do is just get a consultation. And whether you see our clinic here in Honolulu or you end up seeing another Regenix clinic, the same type of thorough, comprehensive treatment plan is similar. We want to take a careful exam, and we use these regenerative procedures similarly with image guidance. I think that's about all the procedures I was going to go over today. Anybody have any questions or anything right now, though?
We have some questions on Zoom, if we could get to those.
Sure, yeah.
Just pull them up. Okay, so first question on the screen is, will the PRP treatment be beneficial if the person is suffering?
So what do you do here? Do I just
Oh, no, I'll take
okay.
it, don't worry.
Yeah, so one thing we always explain to folks is that the PRP injections are not going to work right away. We're taking platelets from your body, we're using your own growth factors and cytokine signaling proteins to turn on that healing process. So it's going to take time to work. If somebody says, hey, I got this PRP shot or this stem cell injection, I felt great within a day, they might not have gotten what they thought they were getting, because think about that cartoon we showed earlier, that process, that healing response takes hours, days, weeks. Some people do get a quick reduction in pain if there's some of those growth factors that are reducing some of the swelling, but typically a platelet injection is not going to be instantaneously feeling better right away. Typically at least 7 to 14 days to start feeling some improvement there.
I think this person said it was arthritis in the hand. I think it was a continuation.
And yeah, oh, I see. Yeah, actually, we do treat that as well. We've got to be very careful. Definitely use image guidance to make sure we're putting those injections. We use ultrasound typically for the hand, the smaller joints.
Okay, next question is 1 year ago, I met an orthopedic specialist at Kaiser regarding complex tears in, meniscus and chronic near complete ACL tear, who told me something like positive results from PRP are well below 30%, majority no change, and a significant amount of negative results. What sources dispute that characterization?
I would look at that infographic that I showed you, which is available on the Regenerative website. Those aren't studies just from us. Those are studies from all over the world. And there is a preponderance of data which shows that PRP is helpful, particularly when it comes to knee problems, meniscus injuries. We have protocols in place in terms of how we go about treating these structures. But unfortunately for some clinics, when someone comes in with knee pain, they'll just say, fine, we'll just put the PRP shot in here. But we need to step back a bit and say, okay, wait a minute. If you're treating someone with a knee problem, and most clinics are simply putting a needle and sticking the PRP anywhere in the knee joint, as long as it's in the knee joint, why aren't the doctors using image guidance to go closer to the meniscus tear, towards the MCL ligament, towards that specific part of the knee joint under the patella where you've lost some cartilage? And that's why I think a lot of doctors, when they say things like, oh, PRP doesn't help, 30% majority, no change. Some of those studies were not done using image guidance. Some of the studies were not done using high concentrate PRP. And that's why a lot of the data is kind of all over the map. But what I like about that infographic I showed you folks earlier is that those are all, the studies in there are all randomized controlled trials. And so a lot of those things are standardized in there. So what I would say to the orthopedic who said this is that you better talk to your academy, because even the orthopedic surgery academies are saying that PRP is something useful to treat structural problems in the knee.
Okay, next question on Zoom. Are the platelets that will be used only from the patient, or can they be obtained from other donors?
Yeah, so currently in the United States, FDA says that in a medical clinic, we cannot process, we can't grow, we can't treat with chemicals. Anything we do that to is now a drug. And the FDA has very specific guidelines on that, what we can or cannot do. So as it goes, the FDA has a classification called the 361 designation, whereby as long as it's used the same day, as long as it's minimally processed, as long as we're using it in the correct ways, we can use platelets or cellular treatment on the same day. There's a 351 pathway, which is where most drugs and biologics have to go through, which involves years and years of testing. It's a very expensive, thorough process. And so most products that are going to be used from your own body, that are going to be used the same day, they fall into that 361 designation that we can use. But the other injections using those amniotic stem cells or cells donated by someone else would become that 351 pathway. And there's no product that is available commercially right now. So the answer to the question is, right now, if you're going to get a procedure with platelets or some type of cellular injection, they should come from your own body. Absolutely.
Okay, next question on Zoom. Will Regenerative work on, is that coccyx?
So,
Sorry.
yeah, that's a tailbone. The coccyx is a tailbone. And for people who fall or get hurt, that can be a very painful problem. Coccydynia is what that's called. But For coccydynia specifically, I haven't seen a lot of data to show that the platelets are going to work for coccydynia or painful coccyx. But in my experience, people who fall and have a coccyx injury typically have back problems or hip musculature or other injuries nearby, which can be contributing to that pain. So what I would say is if someone is struggling with chronic coccyx pain, to make sure they've talked to their doctor who's done a careful assessment to determine, is all that pain coming from the coccyx, or is there anything else that's contributing to the pain?
Is it possible to ask some questions from the room?
Oh, yeah, sure, yeah.
Yeah. I just have a lot on Zoom right now, but yeah, I can open up the questions to the floor, to the live audience here now.
All right, may I ask?
Yeah, absolutely.
Although I'd love my 25-year-old me again, I understand that I can't have it. You've talked about, preserving the joint. If you have a treatment, is it a one-time deal? Is it a once every year deal? And what does preserve mean? Does that mean, I'm pain-free, but I can't continue to expand my activities?
So to me, preserving the joint means any type of treatment we're gonna do, we wanna minimize anything that's gonna damage it. And so I have to confess, the first 10 years in practice, I did thousands of cortisone shots for people. I mean, that's standard of care. In retrospect, was the cortisone probably doing some damage? Yeah. So the way I've shifted my clinical focus now is whatever we put in, I'd like it to be a net neutral. So there are things that you can still get from your doctor, things like a gel injection to lubricate the knee. There's procedures like prolotherapy, which are not gonna damage the inside of the joint. But when we talk about preserving the knee joint, you're right. You know, I have some patients who come in, some triathletes in their 70s, and realistically, they probably shouldn't be training as hard as they do, but that's what they love to do. So when we talk about preserving the joint from a physician standpoint, we're looking at those treatments. We'd like them to be at least net neutral. So what we're doing isn't sacrificing, the life of the joint in the long run. Does that answer your question?
Like if you have to repeat it every year.
Okay. So, and again, it depends. So I have patients we've done treatments for, we'll typically one aggressive treatment, we'll do a booster about a month later, and we might see them back in a year or two, but it depends. I have a couple patients who go skiing every year and they come back in December and they say, I'm gonna be going to Colorado and Montana, I need you to do this for me. So we see these fluctuations in symptoms, but that's also why we combine that with the rehab protocol, because these injections are working at a cellular level. And for a lot of folks who have chronic knee pain or chronic back pain, the muscles nearby are not working the way they should. So the reason why I have these rehab protocols, we want to get the healing process going on a cellular level, then we need to integrate that with the rehabilitation program to retrain those muscles to protect that area. So when we do these treatments, you're right. Ideally, yeah, we'd like a one and done. If we could somehow someday have cultured stem cells we can inject and regenerate enough of that joint. We don't have that now. But it depends on how aggressive you're gonna be and what you're doing. But certainly, I mean, you gotta use good judgment. I don't know if double black diamond is always gonna be the best idea if you have, bad meniscus. Does that answer your question too?
Yeah, and then I was wondering, you gave the protocol, so it's not possible right now, the technology doesn't allow you, or the FDA won't allow you to bank your stem cell, your bone marrow stem cells, so that like you could have like 50-year-old stem cells. So that when you can use that bank and you were 60, 70, instead of having to draw it each time.
So for what we do domestically in the US, in the United States of America, all the Regenetics clinics are compliant with the FDA. We do not culture or grow stem cells. We at Regenetics do have one clinic in Cayman Islands with redundant servers and redundant power so that they can culture and store cells like that. But that's, it's a long way to go. And for a lot of folks who are trying to get relief, that's a lot of steps to take. But typically for our patients, they're just looking at the next 5 to 10 years. They've talked to their surgeon already. And the surgeon said, can you exercise? Can you get through your day? Is it affecting your ability to function on a daily basis? So the short answer to your question is, do we bank any cells? Do we grow any? In the States, we don't. The long answer is there are places you can get that done. And then you got to ask, who do you trust to do that? At Regenetics, all the doctors are board certified in their specialty. They're American doctors. You're not going anywhere. Some of the slides I showed you earlier, from Tijuana or Panama, you have no idea who you're gonna see. But still, if you decide you did research and want to go to a place like that, you gotta ask the same questions, just like when you're here, right? If you're gonna go see a dentist or a doctor, you wanna, where they go to school, what's their certification, how long have they been doing this for, right? Are they gonna be here when I come back in a couple of years and need this done again, or if there's a complication? I mean, I still don't understand how that happened when someone can go to a clinic like that and have no, recourse for that, but it happens.
Do we have any more questions on the floor here? If not, it is 1 o'clock, so, for those that have posted questions in the Q&A function of, today's webinar, maybe, is it okay if they could refer those questions to your, contact info on the slide?
Yeah,
Yeah.
absolutely. The other thing is, I'm on, Instagram as Dr. Dwight, and I'm also on TikTok as Dr. Dwight as well. So you can find me on those platforms. I think we have Facebook also.
Do you dance?
I don't dance on my TikTok, no.
Oh,
Okay, Gil, do you think you can, do a closing remarks for today?
I hope everyone enjoyed this coffee hour. It's very informative. I think that we should, all thank Dr. Lin because he's done a lot of research and, I think I'm excited about the future. I'm gonna call you for my knee.
All right.
So anyway, have a great day, everyone. Thank you, Dr. Lin. Thank you, Dr. Lin.